You're listening to the Physio Matters podcast in association with Choose Health, and this is session 4. Welcome back to the Physio Matters podcast, and many thanks to those who've spread the word of our work. It's much appreciated. And since launching the podcast in December, I've been asked if, like any broadcast medium, we have a publication bias, which I think is a great question. At least to begin with, I've no interest in sitting in someone's front room and having an argument, but equally I've no intention of hiding from the awkward questions. So given time and opportunity, I'm sure we'll have some healthy debates, but interviewing like minds was a sensible introduction. So today we've got another. I'm chuffed to bits to be introducing my good friend Mike Stewart as today's podcast interviewee. Mike is an ex-colleague of mine who was actually my first MSK clinical lead back when I was even younger and even more impressionable. Myself and Mike have a common interest in today's topic, which is the metaphoric use of language and more broadly the biopsychosocial model of clinical reasoning. It was quite amusing for us both listening back to the interview as we quite clearly tee each other up on occasion. However, I promise it wasn't scripted, and for those who've spotted a common theme, no, I didn't have a gun to his head either. The interview split over 2 parts, and I'll see you at the cliffhanger. Nice to see you, Mike. Would you like to introduce yourself for the listeners?
Hi Jack, thanks for having me today. My name is Mike Stewart. I'm a physiotherapist. I work in complex persistent pain. I've done this for the last 15 years. Another part of my role that I've expanded into in recent years is an MSc in clinical education. So a lot of the work that I currently look at is how do we teach patients and explain to patients about their pain. And this is leading down the road of looking at the language that we use and the metaphoric expressions that we use.
Brilliant, and that's an awful coincidence because that's why we've got you on the show. But interestingly, where have you come from? Where is it? What led you to today?
Well, I think like most people who, like me, trained in the mid-90s, there's been an interesting journey from a paradigm that during the 90s was a very, very biomedical and structural, and I always think back to what I used to do with patients and see myself almost like a fiat physiotherapist, the fix it again thanks idea of people would come through the door and I'd help them like scratching a mosquito bite, and then next week Mrs. Wilson would be back there again. Thanks a lot, Mike, that was lovely, do it again, thank you. And I never really felt like I was achieving a great deal. The results weren't really there in the long term. So I suppose based on reflections of how I was helping or not helping my patients, I started to look at how I could adapt, and that's led me down a path of looking at a biopsychosocial model, which is what we're going to be discussing today.
Was there a moment where it shifted, or did that happen quite naturally?
I think a little bit of both, really. I think it was on the horizon. I never felt comfortable with the paradigm, even as a student back in the early 90s. I always felt that it wasn't quite me, but I was one small voice in amongst a very large, loud voice. So I think gradually over the years, as I started working alongside people who had a similar outlook to me, I think my voice started to feel like it was more valid. And then suddenly you start looking at the research and you see that there's a lot of evidence from very eminent thinkers on an international basis, and I think that gives you confidence in evidence.
The way that the evidence-based medicine model has developed in our industry, that has happened to support some of the thoughts that you had early doors, do you feel?
Yeah, very much so. Yeah, I think we'll talk more about the biopsychosocial model of management, and I think one of the criticisms that we often face is that it's less than scientific, and hopefully I spend some of my time teaching clinicians and patients how that's not the case, and how actually this is it runs deep, the way that we think about a biopsychosocial model, and it makes sense to patients, which, let's face it, are the most important people in amongst all of this.
So your part of your work is delivering clinical education to obviously clinicians, but also taking that and not changing it too much for the way that you teach patients through your No Pain series. How did that develop?
Well, I think I've always thought of my patients in the same way that I think of learners. I've always enjoyed practice-based education with students and peers, and I don't think that patients are far removed from that. And especially now I'm looking at clinical education from an MSc perspective and looking at the theoretical concepts behind education. It turns out to be very much the case that the patients do have to learn in a very similar way to the way that we learn as clinicians. So I make no bones about the fact that the course that I run for clinicians is not dissimilar to the course that I run for patients.
Right, interesting. So a good place for us to start really would be the difference between the biomedical and biopsychosocial models, not in a dictionary definition version of events, but what do you think the pros and cons are of each of those models? Can they coexist?
I think they can, and I think they must coexist, really. I always think the bio part of a biopsychosocial model is referring very much to the biology, to the anatomy, to the physiology. We must consider that within the broader context of the psychological and social aspect. I think, though, to look at the disadvantage of the biomedical model, and particularly in our line of work, is that it's very linear in its thought. It tends to lead us down one particular road. And thinking about how human beings work, they're not as simple as that. We're not dealing with motor cars here. We're dealing with people.
And so the plus side of it?
The plus side of the biomedical model, I think it has a very technical, demanding role, and I think we're able to pass that on to patients. I think the evidence for a biomedical approach is very much in keeping with what patients believe. So I think there's definitely a sort of an affiliation to how we all think about pain. If we think back to Descartes' model, which still exerts an influence on clinicians and patients, on us all, of the Cartesian model of pain equals damage and damage equals pain. And I think the biomedical model fits that, so it works for a lot of people. So there is an advantage there. However, is it in line with the current evidence base? Not particularly. It's moving to become outdated, possibly.
So the biopsychosocial, we could call revolution in recent years, particularly in terms of evidence anyway, is something that we can draw a lot of positives from that as clinicians and try and instigate those changes. However, what's the downside to biopsychosocial? What's the dark side of it?
Well, I think you can, like most things in life, you have to have a degree of balance. And I think you can, as a clinician, be guilty of becoming quite dualistic in whichever camp you're in. We can very easily head down the road of thinking that the biomedical approach is the be-all and end-all. I can certainly recall clinicians that I've worked with in the past who have said, well, you have to work under a McKenzie paradigm. We're unable to move outside of that. You have to do what we say. And I've also worked with people with a very biopsychosocial outlook who will refuse to listen to anybody that has a structural view on things. I think you need to have both, and I think some of the educational work that I've looked at comes into this really in very detailed work from Perry back as far as 1970. Perry looks at the stages of learning development moving from dualism, where we have this black and white, right and wrong idea, and then moving towards relativism, where everyone possesses only a limited version of reality and no one has a perfect perspective. So this is where we have critical appraisal skills come from, the ability to accept and acknowledge that nobody has a perfect perspective.
Using those frameworks of learning, because of the shifts in ideas and the shifts in evidence, people take sometimes a more orthopedic or structural or biomedical model, have developed towards a more biomechanical model without quite taking the plunge into maybe biopsychosocialism. That in-between point, is that useful for the profession, do you feel?
It serves a purpose in the journey of most learners, I think, and I think some people remain within that one dualistic idea of how practice works, and it's quite interesting because, again, when you look at the research into how we educate people from the educational literature and not within healthcare, Sean's work looks at how we think and how we influence people through the way we transmit our knowledge. And if we have a very technical rationale of how we do things, i.e., we have a perfect idea of how things operate. Sean always considers that we, with a technical rationale, that we sit on top of a mountain, surveying over everything, and being able to understand everything that's going on in practice. That's not always the case. I think we can fall short if we see ourselves on top of that mountain. The opposite of that is the professional artist viewpoint, which is we're in the swamp. Practice isn't always as clear cut as we might like to think that it is. And that's certainly where our patients are. Our patients are stuck in that swamp, so we have to get down there and join them sometimes. And that's where I think the biopsychosocial model achieves that.
So we can sometimes oversimplify, but equally is guilty of overcomplicating.
Yeah, and I think that's a very difficult thing, is to keep things simple. I always, in my presentations to clinicians and to patients, I try and get across the idea that a biopsychosocial approach is based in science. If we think of, I use a couple of quotes from Albert Einstein, and Einstein once said, from clutter, find simplicity. And I think that's a lot of what the biopsychosocial model aims to do. We have to have good communication skills, but within and amid a complex, cluttered environment of the biopsychosocial outlook that we see with patients.
In all paradigms of learning and developing as clinicians, both physios and other health professionals, we have a seeming desire to categorise and box people in. That's something that is also translated in the educational literature, I understand.
Yeah, certainly. I think categorical thinking is very normal for us as human beings, and if we think about how that works, next time you go into a DIY store and you look at a paint chart and you see the colour spectrum, those have been designed because we think very much into small boxes. If you ask people, what do you remember about the colour spectrum, they'll very much say, well, I can recall the blues and the reds and the oranges, but you can't recall the vague colours that go in between. So as humans, we recall information very, very well when we think in categorical terms, but there's a big problem when we consider how that works for our clinical reasoning. And I use a good way of explaining this with clinicians and patients. Jack, if I was to try and get you to think of I want you to tell me how you pronounce this word, and I'm going to give you 3 lots of 3 letters. How would you pronounce this as one word? The first lot is CHO.
Okay.
How would you pronounce
Cho.
CHO? Yeah. And then PHO.
Fo.
Yeah. And USE.
Use.
Okay, so stick them all together now. What do you get?
Cho for use.
Cho for use. Okay, that doesn't seem to make a great deal of sense, does it?
No.
So if I was to get you or the listener to write that down and just take a second to think about what that now spells out, what have you got there?
Right, okay. Chop house?
Chop house, yeah.
Okay.
Yeah. So, that can really affect how we reason. And if we think about it, the way that we think should be contextual. We should think broadly. Sometimes with patients, I'll get them to close their eyes, and I'll put in front of them a very, very close distance to their eyeballs a picture of the Mona Lisa. And I'll say, open your eyes and tell me what you're looking at. And they can only see a very, very small version, a small perspective of the bigger picture. You pull it back, and of course they can see the Mona Lisa in all her glory. And that's an important way to think as a clinician, I think.
So clever little lessons in perspective, and you use, say, the chop house idea with patients as well as the Mona Lisa one.
But yeah, and I think that's a way of getting across to patients and clinicians, and we keep coming back to this idea that they're all learners at the end of the day, that the biopsychosocial model really is not a simple neurophysiological phenomenon. It's there's many factors that influence pain perception, and when we take into account all of those factors, we have to step back and look at the bigger picture. And again, we maybe look at this with how an MRI scan education process would work. If we think about the CHO is maybe putting all of our focus into how the L4-5 disc looks. Why is the patient not getting any better when they've had injections and surgery? Well, maybe you're missing the FO and the use. You're not seeing the broader picture here.
Okay. And in terms of applying perspective and trying to get clinicians to do that, that's something that's one of your aims, I know, at the moment. You've said about trying to change the perspective of a consultation, even at a fundamental level. Could we change the need to cure to an opportunity of change?
Yeah, I think so. I think, again, I refer back to Einstein. Einstein said, in the middle of difficulty lies opportunity. And I think the opportunity that we seek with our patients with persistent pain is to try and assist them towards self-efficacy. If we're trying to think of the way that we work as a cure, then are we going to always work? Is that always going to be useful for us and for our patients? I can think of certain people I've worked with who've had a degree of burnout from realising that the profession doesn't work that way. We have to maybe step back from thinking that we can always help and always cure and be more realistic.
Okay. To bring it onto something slightly different, there is a lot of research out there at the moment for what's called a catastrophizing or a dramatising of events that could be considered a pain perception issue. You have a more evolutionary thought on that?
Yes, certainly. I think we have to always look at whether something is adaptive or maladaptive. What are the coping strategies that patients use when they have long-term persistent pain? And always the question that I think in my practice is what this person's displaying adaptive, helpful? Is it useful? Or is it maladaptive? Is it getting in the way of how they manage things? And if we think about catastrophizing, and I think lots of people use this in a negative effect, in a negative way, and they see catastrophizing as a yellow flag and that we should avoid this. And actually, if you look at how animals work, and we are, after all, just animals, we all catastrophize. If people didn't catastrophize, there wouldn't be hospitals and physiotherapists and doctors. We need to display that we have a problem and we need to seek help. That's a useful thing at the first point. So the question, I suppose, is when does that not become useful?
So when is that maladaptive?
Yeah, when does it become maladaptive? Okay. And I think that's a question that we as clinicians and them as patients need to ask each other.
And just to clarify for the listeners, we're not just talking here about very complex, more effective components of pain. This is pain per se.
This is everybody, and I think, although my work is particularly centred around very complex persistent pain patients who've often not found help in other areas of the healthcare system, it also applies to the 2-week-old ankle sprain. Is their behaviour adaptive? Are they heading into what Vlain and Linton term as a positive outcome towards confrontation of their problem and recovery? Have they got an internal locus of control? Do they understand how to try and achieve that without healthcare and without guidance? And some people do. If everyone was like that, we'd be out of our jobs. But often patients head round the wrong side of the fear avoidance loop. They head into disuse and disability, and that's where things then become maladaptive.
And so how would you use comparisons to other diseases or ailments or chronic issues to help patients to understand their pain and their problem?
Yeah, I think there's a big move within the literature at present to try and reframe pain and reframe it as a condition in its own right, really. And if we think about any other persistent condition, and we think about diabetes and epilepsy, I know I suffered from epilepsy as a kid, and if I think back to how that helped me, doctors sat me down and asked me, what is epilepsy? Let's discuss that in a Socratic sense. So we had to try and consider, they made me consider, what is epilepsy? How does it work? What are the nuts and bolts of it? What do I have to do to make sure I stay okay? What do I do to, if I want to get worse, what are the things that I would have to do? So I had to confront that, and in doing so, learn how to manage it. And this is the same with all of our patients. I often think I quite like it when I see a patient in front of me who has a comorbidity of diabetes, say, or MS or epilepsy. I'm able to link that condition and how they manage that, which is usually very well, to how they're poorly managing their pain condition. We have to get them to see that there's a link here.
Even something potentially episodic such as epilepsy.
Yeah, we all see these patients, don't we, who get pain on the odd occasion, that they might have the odd sort of 2 weeks on an annual basis where they're laid up in bed. How do you manage that extreme severe flare-up? And it's again, think about how the epileptic would do it. And I always think if you're a doctor in A&E and you have the patient coming in every 3 days for insulin injections and for an inpatient stay because they're not managing their diabetes well, there's a problem there. Equally, if we come back to our line of work, if we have the patient that keeps coming back to your practice every 3 days for a manipulation, can we see how that maybe causes a few problems there? Again, is what we do adaptive or maladaptive? Always come back to that question.
So we've talked a bit about modern medicine there, with diabetes, epilepsy, MS being examples of that, and modern medicine serves those conditions relatively well, we would argue. How does modern medicine sort of fail us a little bit in terms of the biomedical model?
I think there's many examples that you could use, but I think the one that I'll use today is if we think about MRI scans and X-rays. And I think, we always sit and show our patients through their MRI scans and educate them, or I hope we do. I never used to, but I find it very helpful to do so. But again, it comes down to perception and interpretation. So I always quite often see patients who have very healthy looking scans, or scans that always have some elements of age-related degenerative changes. And I always think with when I talk to patients and clinicians about how we explain scans to patients, there's 6 fundamental questions that come up. Would reassurance help? Yes, often. Put yourself in their shoes. Do the findings match the clinical picture? That's a really important thing to look at. And what's normal for the age group? If we got 1,000 gentlemen of your age, what would we normally see? I always think that MRI scans are a little bit like going into a Formula One team, taking your car in and leaving with them for a week. It's a very, very fine tooth comb. We're always going to find brake pads and shock absorbers have got some issues going on. So does that matter? Does your car still function? That's the important thing. Is there a surgical target? And if so, do we need to head down that line? Can we safely get the patient going? And can we turn negatives into positives? In other words, do we always explain osteophytes as a negative thing? Not if we think about how in evolutionary terms they work as spreading load and trying to assist. And I think also when we look at a normal MRI scan, patients are often confused, and I see lots of patients who will say, well, okay, I've seen the doctor and he said that my scan looks normal, and that's left me with the question, well, is it all in my head? Where's the pain coming from? And what I tend to do with patients is I sit them down and show them the computer, the desktop that I have in front of me that I'm showing them the image on, and I show them the wires that I can see through the vent on the computer, and I say, well, if we got a team of computer experts from around the world to sit and stare at the motherboard inside this computer to look at all the circuitry and look alone, nothing else, no tests, could they tell if there's a problem with it? And the answer is no. I mean, it would be foolish to think that you could see if there's a problem with a computer by looking at the wires. We can't see how lively, how active those electrical circuits are, those neurons are. And that's the problem with an MRI scan. We're looking at structures. We're not seeing how the structures are functioning.
So if there's a disparity between hurt and harm, which we know of, but what is pain then at a fundamental neurological level?
Well, I think we need to trade the word pain in for sensitivity. And empathy and sensitivity all roll into the same ball, really. And I think it's best to answer that question, why do we need a nervous system? What's the purpose of a nervous system? And it does, on one hand, serve as a critical protective device. If we think about it in its adaptive sense, from a pain perspective, it's really useful. if we don't have pain, if we see what happens to patients with a clinical inhibition to pain, they don't feel pain. They don't live very long. They don't know if they're injuring themselves. So pain is a really important thing. But, and there's a big but, it has a problem. If we think about all alarms in the world, they don't function perfectly all the time. If we think of our nervous system as an extremely complex alarm system, our more simple alarm systems that we use in the world have issues. They don't always function at an accurate level. And I think one way of explaining this to patients is to explain the fire alarm that goes off for the small piece of burning toast. The small piece of burning toast often in our hospital has 9 fire engines running in to try and save the day. In the years that I've worked where I work, I've seen that many times. How many fires have I seen? Not many. None, actually.
Okay. And the sensitivity of the nervous system, or that model of thinking, that's something that's sometimes often, difficult to get across to patients, as well as other clinicians.
Very much so, yeah. And I think this again comes back to our Descartes' Cartesian model of our belief system of pain equals harm, and there must be a structural cause all of the time here. And although it plays a part, and as we say, we think with not in that dualistic sense of biomedical versus biopsychosocial, I think we have to think of ourselves as, well, when we get asked that question by patients, where is my pain coming from? Why is my nervous system so sensitive? We have to explain how LTP works, long-term potentiation, that nerves become better at doing what they do if they repeatedly do it. A good way to explain this is thinking about how we learn to drive a car, or how we learn to potty train, or nerves get better at information the more they repeat it.
Okay, and so with sensitivity, if the body is behaving like an overexcited fire alarm system, then what are your top tips on getting that part across? So getting that initial buy-in to a sensitive nervous system model, in which before you start teaching how that occurred, how do you get them to buy into that?
Well, I think always a good thing to do is reconceptualize it in the patient's mind. Use the patient's experiences to try and prove your point. If, for example, you have a patient who's saying, well, I get really bad flare-ups, despite the fact that all I'm doing is trying to peg the washing out, then you think, well, the amount of pain that you receive is useless and out of proportion, in the same way that the 8 fire engines rolling up to the piece of toast is out of proportion, or that you jumping up to the kitchen to the smoke alarm for something that's just a small bit of heat is out of proportion. So I think it's important to get across to patients that sensitivity is normal, and I suppose it leads into the question of, is it all in my mind? Sometimes people think because we're talking about the brain here and sensitivity that we're talking about psychology, and we are to an extent, but I sometimes think I explain to patients that we all have that moment where we're lying in bed of a night and we just drifting off to sleep. Normally my wife punches me with this when this happens, and we get that falling off the cliff type idea where everything's relaxing and all of a sudden we're thrown down the side of a cliff, or we feel like we're falling off the bed. And the question to ask patients is, well, does that feel real? Can you stop that mid-flow? Are you able to interject there and to stop your nervous system from having that perception? No, you're not. So pain in all senses is as real as the falling off the cliff idea.
Okay, and so getting that across to patients is tricky because they are almost bred to trust their body, and I need to know what my body's telling me. And so you're saying that the brain's playing tricks on them to some degree. Any other tricks that you have up your sleeve for getting that across, the brain cheating them?
Yeah, I think there's a few. I think you can use, if we think of what are the 5 senses that the nervous system does: texture, taste, sight, smell, hearing. We can use visual illusions to try and explain to patients how always our retinas deceive us. We're not able to get an accurate picture. We can also think of the milk that has blue food dye in. Nobody wants to drink blue milk. Just tastes like milk though. It's no different. So there's lots and lots of tricks that we can use here. So yeah, I think we can explain how this works across the senses, but let's make it relevant to the patient in front of us. After all, we're in physiotherapy. There's only so much that we can talk to them about how hearing and sight and vision and things work, and some people might not get that. So I think always a good thing to do when we look at persistent, say, back pain patients, we often see two erector spinae muscles, which are looking like two huge security guards that are locking doors all the time. Very, very overactive, protective erector muscles and hamstrings. And I always try and get that across to patients to show them that at a subconscious level, their nervous systems learn to tell those muscles to tighten by getting them to tighten their bicep. If they tighten their bicep and they can not very easily extend their arm, they can then do the opposite and relax their bicep and extend it beautifully. But they're in control of that muscle. They can consciously switch on and switch off their bicep. So I then bet them whether they're thinking at the same extent with their lower back muscles, with their erector muscles. And of course they're not. This is a subconscious learned pattern of behaviour.
We're all under an understanding, or we should be under an understanding, of pain as being an output rather than an input. And if it's an output, it can be learnt consciously and subconsciously through a process. Any skill, any act. You've mentioned learning to drive, for example. Do you put that in a similar way to patients?
I think if I have a patient who's sat in front of me who's had pain for 15 years, and their expectation is that I'm going to get rid of that pain in the next 6 weeks. In whatever way that I can, I tend to say to them, well, if we think of pain as information, if we use Donald Hebb's rule, which has stuck with us since the 1940s and has been expanded on since then, nerves that fire together, wire together, or they potentiate, they become better. And this again leads into Melzack and Wall's neuromatrix ideas of how the brain learns information. I sometimes say to my patients, well, if you'd learnt French every day for 15 years, if I'd handed you a load of French textbooks and a load of French podcasts and got you to live in Paris for a couple of years, would you now be good at French? And of course, they say, yes, well, I'd be fluent. The question then is why? Why would you be fluent? And most patients get the point. Okay, it's wired in, it's into the wires, it's hardwired in there. Yeah. So the next question then is, could I then could I make you forget every single word of that French in the next 6 weeks?
They'd still know how to say bonjour a few years later then, yeah?
Yeah. The opposite's very true. Nerves that fire apart depart. I can't recall my A-level biology exam like I could years and years ago, but I still remember elements of it. So can we get our patients to manage pain better by deprogramming or reprogramming? Well, yeah, that's what neuroplasticity is. Does that depend on how plastic the patient is? Very much so.
Of course, and influencing that plasticity is important to get across unlearning before learning.
Yeah. And I think, in one sense, if we think about within a biopsychosocial model, nerves that fire together, wire together, very, very true, but thoughts that fire together, wire together. And this moves into then how CBT affects patient outcome. So maladaptive cognitions lead to maladaptive behaviours. If I think, or if I get a thought into my patient's head that their disc is causing major problems and they need to not bend, they're not going to bend.
That's another gap to bridge, isn't it? So we've got we've got a patient that's bought into that sensitivity model because we've used all the tips and tricks such as what you've just described. They understand this over-alert system. Bridging the gap into them recognising that thoughts are impulses too, that can be delicate. That can be sometimes where people then get lost again and we have the same question, but it's not in my head. You said it wasn't. How do you bridge that subtly?
I think often it works best when we get them to use their own experiences. We talk about the triggers that trigger pain. So in terms of contextual triggers, environmental triggers, which I think is a big move in the literature towards that. Pain isn't a simple neurophysiological phenomenon. We we have to get the patients to interpret what they're experiencing on a day-to-day basis. And I think there are ways that you can do that. But you're right, it can be a difficult thing to do, and it requires good communication skills.
And you use the Socratic techniques that you were discussing, so you get the patient to come up with their own example of that.
Yeah, very much so. And I think in my work looking at how metaphoric expression works, our communication has to be dialogical. It has to be collaborative. It can't come from one side of the cubicle. We have to try and get patients to see how they're living their life and how that might affect them.
So if we're talking about sensitivity, what are the main factors that influence sensitivity in patients, and how do you get that across?
Well, I think there are a number really of triggers, and especially I run a group, an educational group with persistent pain patients, and again, in a Socratic sense, we get them to try and pinpoint what those are. And it's interesting that on a one-to-one basis in a cubicle with a patient, often they'll come up with, of course, a physical trigger. So they'll discuss the physical components of if they go in the garden for too long, or, we know how that works as a physio. Some will pick up on the emotional triggers, on the stress response triggers. And they'll say, well, it definitely gets worse if I've got some more things on my plate. So we can talk about how stress biology, and especially Professor Sapolsky's work, Why Zebras Don't Get Ulcers, I often urge my patients to read that book. We can talk about how stress biology and how the endocrine system affects pain. But things that patients sometimes touch on would be contextual triggers. Why does it hurt more if the mother-in-law's in town, and it doesn't hurt so much if I'm out with my friends at the football match on a Saturday? Or why does it hurt more if my football team loses on a Saturday but it wins, I don't feel it as much? So the context of pain is important, and there's many ways that we can explain that to patients. I think one way of looking at this is how Manteo Mitchell at the 2012 London Olympics managed to run his leg of his 100-metre relay whilst having a horrible spiral fracture to his tibia. When he was questioned afterwards, he said, well, of course it didn't hurt. It hurts afterwards, but it wasn't going to hurt in the context of the situation. Billions of people watching me, and 4 years of training, and a team who were looking to me to deliver. The other factor which isn't often spoken about, and I always think that the patients who really interest me are those that come with questions that challenge my thinking. And this leads us into environmental triggers. Why, when we get patients in front of us who say, Mike, I don't understand why it hurts when I stand at the bus stop in the morning for 10 minutes, but I'm fine if I go to a friend's wedding for 3 hours and stand. What's that about? I think that's a really important question to always ask our patients and ask ourselves, what's that about? How does that work? The way I tend to explain that to patients, if we think about the 5 senses within the nervous system, and we think that we can make associations between songs that you might have heard that take you back to your childhood or to a holiday particularly, or we think about smells that take us back to a previous partner in life years ago, or if sights and smells and hearing can trigger associations and fire and wire impulses and action potentials, then so too can environment. This is why people often get pain when they're ironing at home, but they don't when they iron when they go abroad on holiday. Why you would iron when you're abroad on holiday, I don't know. But
yeah, that's a different issue altogether, isn't it? You also have the flip side, don't you? You can have someone that's pain can be worse when they're out with friends and okay out of that context because it's affecting them more, it's limiting them more.
Yeah, context is unique. Context is individual, and I think this draws on to the important point as clinicians is we need to be adaptable. We need to see every person as being unique and individual, and there's no hard, fast rule and set method that we need to employ here, which again moves very much away from this technical rationale.
In categorical thinking, it's a 10-year chronic back pain of an unemployed lady could be treated in not a dissimilar fashion to an athlete with 2 years of knee problems keeping them off a rugby pitch?
Yeah, I think the question is always, regardless of who's sat in front of you, whether it's a professional athlete or a 55-year-old with back pain for 30 years, do they have a biological component? Well, of course they do. As long as they're breathing, then yes. Do they have a psychological component? Yes, as long as they're thinking. Do they have a cognitive component? Yes. And do they have a social component? Yes. So the biopsychosocial model works in every single context. We can't separate this out. There's no such thing as a category of persistent pain patients. We are all persistent pain patients waiting to happen, in one sense.
So we're pre-chronic.
Yeah. In one regard, it's just some of us will manage those idiosyncrasies that come with what we experience as pain and our perception of pain, depending on who we are and what we believe and our context.
Pain being the body's and brain's perception of danger brings up the context of, the thought of pain being a threat, okay, to some degree. Is that something that is being researched enough? Is it something that's out there in the literature?
Yeah, I think it is. I think Moseley in 2007 looks at pain as a threat and has a model of the question that the brain is always asking, and I always get patients to think of this. The brain is constantly asking, how dangerous is this really? And it's basing that answer on beliefs and knowledge and logic and expectations and cultural factors and previous experiences and sensations, nociceptive inputs. And it's constantly requiring meaning and expectations and apprehension and anxiety, and in return it will give us some output. And I think a good way of explaining this to patients, if we think of where some of the pain science originated, was with Beach and his colleagues during the Second World War. As a doctor in the field in the Second World War in northern France, Beach noticed something quite interesting, which was, why is it that soldiers who would come in with quite nasty injuries but not life-threatening would present with very little in the way of pain? In fact, some of them would have smiles on their faces. The context of that is, I'm safe, I'm going home. Yes, I might have lost a foot, but I'm not dead like a lot of other people that I know. What's the answer to the question, how dangerous is this really? Well, not really. I'm going to survive here, at least. I'm getting out of northern France. When Beach and his colleagues looked at very similar injuries in the civilian population, in people who'd had their houses blown up and their kids killed, and massive psychological and social traumas, the brain's asking it's asking the same question. It's coming up with a very different response. Its threat level is hugely increased based on all of those factors that we've just talked about.
I know that functional MRIs come to the fore, and there's a lot of funding in and around neurobiology in that sense. How can we interpret that and use it in a physiotherapy or other healthcare sense?
Yeah, I think there's quite a few ways that we can do this, and I think about how I do this with a group of patients, and we almost set this up quite nicely, I think, by talking about how we can't see pain. Lots of patients come in and they want to display the fact that they have pain. They'll show it's a coping strategy. Sometimes they'll show they have pain by using a mobility scooter or a walking stick or an aid, and it's a way of expressing the fact that they have pain, because unlike the plaster cast, we can't see it. And the same thing goes, I suppose, for looking at neck collars and lumbar supports that we see quite often. But actually looking at fMRI, we can see pain. We know this, and I think getting that message across to patients and showing them images of fMRI scans, for example, Sharma, Gupta and Oliveira in 2011, I use slides from their study which clearly show a reduction in central sensitization based on pain education. This isn't based on lots of manual treatment. And I think this always comes back to the interesting question that I ask myself as a reflective practitioner. Why is it that I'm able to affect patient outcomes without doing physical things? I still use my hands. I don't like this hands-on, hands-off debate. We have to employ all of our skills. You can't make a cake by throwing flour in the bowl. You have to employ a very complex recipe for a complex problem. But how is it that we can help our patients by educating them and using that as a tool of treatment?
So the education could help them move, which could have been the thing that changed the fMRI result, but we don't need to care, do we?
No, not really. It's do whatever we can to get them going, really. And I think, where does that begin? First of all, deal with their concerns. That requires communication. It requires education. And then deal with the rest of the things. Deal with the consequences that's presented over the years. And I often say to patients, one of the things that you have to do is see us as teachers first. We're here as communicators and teachers, and then we're here to do the physical aspect of what's caused a problem here. And obviously that depends on the individual. That will vary.
So we come to if this patient has embraced all these things, and they understand the sensitivity model, they also understand all the influences and the context of their problem. We need to start broaching the reframing of that and recontextualizing the situation. How do you best go about that?
Well, I think naturally, my brain works in a very metaphorical way, and for years I always thought that was just me. And actually, when I look at the literature surrounding metaphors and pain reconceptualization, which I have recently, it's not just me. If we think about throughout the history of science, Einstein's theory of relativity came from a sledge dream where he was getting faster and faster in his dream on the sledge and lights were becoming blurred. Newton, of course, with his famous falling apple and planetary gravitation, and Max Planck's quantum theory through vibrating cello strings acting as electron orbits. So we can see that fundamentally science is based in metaphor, and Lakoff and Johnson always consider that metaphoric expression is fundamental to human language. We always have to use it. So metaphors work. However, there can be a downside to metaphors sometimes. They do provide an effective and meaningful transfer of complex and rather abstract information. Great. On one hand, they open an outlet for new perspectives, but this has to be dialogical. It's got to be Socratic. We can't go putting words in the mouths of others. So
you use a metaphor based on a tale that has been told by a patient?
Yeah, I always think in practice it does take two to tango. This is a two-way thing. We have to come up with collaborative, dialogical, Socratic ways of explaining pain. Do we do that in a very technical sense, or not if we want to lose a lot of our patients? So we have to do it in a metaphorical sense. However, there is a downside, though. I think in an essay that I've recently produced, which is published and will be available to your listeners, I say that metaphors provide a frame through which we paint unique cognitive landscapes, but we must remain mindful of our eagerness to impose our brushstrokes onto the canvases of others. And I think that's a really important point. I think often we talk a lot. In our practice, often we don't allow the patient to talk, and I often think that's one of the problems when we describe how pain works metaphorically. The patient has to come up with their own idea, and that's a skill to try and to sit back and let the patient explain how their pain works for them.
So metaphors can be maladaptive? They can certainly. I think a good example of this that comes out of the literature is a negative version of how we would use metaphors would be looking at the crumbling biscuit or the disc as the jam donut. I mean, that's not a particularly helpful image to have implanted into your head, and often we see this in practice. There's a more broad metaphor that's used in medicine, which is medicine is a battlefield. And
this idea that the patient will seek help at a minor skirmish level with some pain control, and then if that doesn't work, they move into the tank and armoured divisions, which is then the injections, and if that doesn't work, we go for the nuclear bomb, which is the surgical interventions. And the idea that the war can be won with this biomedical escalation, which is all points promoting dependency on the practitioner. And also, Wiggins in 2012 felt that this type of metaphor lays failure at the door of the patient, not with the treatment. And the idea that failure lies with the patient and not with the treatment really leads into failed back surgery syndrome that we sometimes see. And I think that's not a particularly helpful way to view our patients. I think there's another side to the battlefield, though, which I always consider, and I know if I reflect back on my worries at 4 o'clock in the morning as a clinician, and it's always feeling as if I'm incompetent at my job. And I think if I think about me as a soldier trying to fight the battle and win the war, under a biomedical paradigm, I was never able to really achieve that very well. This is why I suspect that I've led into the path that I've gone down today. It's moving away from that.
So you can win the battle sometimes, short-term interventions, but you'll never win the war.
Yes, very much so. Yeah, which is the scratching the itch phenomenon that we discussed at the start. But there are some very positive ways that we can use metaphor. And I suppose a good example of that that's been looked at a lot throughout the literature is journey metaphors. There are always avenues to explore. The roundabout that always has that extra sort of cul-de-sac that we can go down and come back out of and explore another route. Light at the end of the tunnel, which offers an optimistic cognitive reconstruction and facilitates personal growth. Journeys can be arduous. Journeys can have problems. Life is not life without some difficulties along the way. And sometimes, again, coming back to the sensitivity of the nervous system, I always think a good way to get that across to patients is most of our patients are parents or grandparents, or they've looked after children of friends or colleagues. So I think if you were to be walking down a busy sidewalk or pavement, and we have a busy road at the side, and one of the kids goes running off for the traffic, what's the first instinctive response that you make? It's to try and save the child or to run after them and grab them. I always think back to photos of me as a kid. I had reins constantly on. I was a twin, or am a twin. So I think we have to get that metaphorically across to patients, that your nervous system sometimes will react by being an overprotective parent. It will ground you if it thinks you've done too much. You might feel fine going to the badminton court. How does your brain see that?
And so your brain can put more reins on to try and protect more, or it can avoid the road altogether.
Yeah, and this is the where people fall down sometimes, and Butler and Moseley talk about the idea of people who take one path, which is the no pain, no gain, keep pushing into things, gas mark 8, not gas mark 4, and they don't get very far, a lot of these people. We then see the other side of that, which is where fear and apprehension takes over, and they start to withdraw from things with the obvious consequences that brings.
Because there is some more complex neurobiology that underlines all this, and we will come on to that in a second. Before we do, I understand you're of the opinion that we can sometimes overcomplicate things for our own benefit, or lose sight of functional goals.
We always talk about goal setting with our patients, but I sometimes wonder how effective we are at doing that. And I think it's really important to always come back to the point that patients are the central part of this. We should be making everything meaningful to our patients. So in talking about goals, we have to get them to maybe write down what is it that you're struggling with. I always think of functional rehabilitation and goal setting as being very helpful for me as a clinician. It allows me to break down that one activity. Let's say, for example, cleaning your car. What do you need to clean your car? Okay, where do I need to develop you in terms of strength? What do I need to look at in terms of weakness? I always think of that acronym, keep it simple, stupid, KISS. Where are you weak? Where are you stiff? Where are you tight? Where are you maybe cognitively not on the right page? Maybe where can I adapt that? So that again comes back to the combined effects of the biomedical and the biopsychosocial model working together.
So if we go too far into the pain science, we'll lose track of the fact that we still need to get that person trained, or might need to get them to move biomechanically differently.
Yeah, and I think, we've all had those patients that will say, okay, enough of the talking, let's get started. And we've all had those patients who want more of the talking and they don't want to get started. They use it to try and prevent the physical side from being instigated. So there's a time to talk and there's a time to do, and there's a time to combine the two together.
And your patients, they don't always have these long interventions that last many years. This is sometimes, because it's a principle, they sometimes take that on and go away and act on it quite quickly.
Yeah, we want them to become a self-directed learner, and all self-directed learners should really have the ability to continue at a level of self-efficacy. Bolton in 2010, when she looked at self-directed learning and what attributes that they should embrace, it's certain uncertainty that I think we have to get that across to patients. Expect the unexpected. Serious playfulness, so they have to be able to think sometimes a little broadly, not to think rigidly. And we talked about conceptual thinking and unquestioning questioning. I always think this is very true for clinicians and patients. They have to think there's no such thing as a stupid question. We have to sort of consider every question as valid, and they always have to question why their body's doing what it does. But at the same sense, they have to have a degree of fearless, thoughtless movement, not thinking about it, not worrying about it, behaving normally, as sometimes the famous sports brand says, just do it. That's how most mammals exist, is just by considering what they do in the physical realm and not overanalyzing information.
We best not mention that brand by name. I can't afford the rights, I don't think.
No, let's steer away from that.
Okay, very BBC of us. So understanding neurobiology and the higher centres and how they operate is really useful as a clinician to understand, but is that essential that we put that across to patients, and how do we do that best?
Yes, I think it is. I think it's important that us as clinicians have an understanding of the complexities of the nervous system. We must do that, and the evidence points us in that direction. But the question always comes back to, how do we make this meaningful to patients?
And that was session 4. I hope you've enjoyed it, and I look forward to feedback on the ending. I like to think that we produce a hybrid where physio education meets soap opera. Let's see how that goes down. A huge thanks to Mike for his time, and I hope you'll tune in for part 2, which will be out in a month's time. Mike has a new website up and running, which is both clinician and public facing. Head to nopain.co.uk, which is spelled knowpain.co.uk, for a wealth of resources, as well as Mike's new Twitter handle, which is @nopainmike. The final few plugs: head to choosehealth.co.uk for subscription to the show notes newsletter. Rate us on iTunes and find us on Twitter. Our team tweet from @TPM podcast, and I'm @choose_health for post-show discussion and feedback. Be great to hear from you. And this podcast literally wouldn't be possible without the podcast team. Huge thanks this month to Rich and Charlotte, who cut out my bad jokes and banter me on Twitter like they're trained to do it. So all that's left is for us to go back to Mike Stewart, who's going to see us out.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Any more cheese and I'd be fondue.